Okay, thanks guys for coming and listening to my presentation today about the LVAD. So we're going to get started, and if you have any questions you can ask me, but we'll have questions and answers at the end as well. So the purpose of this presentation, not only is it my capstone project to finish up my BSN, so I thought it would be a good opportunity for us to learn about something we maybe don't know a whole lot about. So I asked Regina, and she suggested doing some research on the LVAD. The LVAD stands for Left Ventricular Assist Device. And so what I've kind of put together here is a presentation that goes over nursing interventions surrounding the LVAD. So our hospital is going to start doing this procedure in the next 2 years or so. So this is just kind of a start on us learning what our responsibilities will be to our patients. So we probably know this, that there are almost 6 million people diagnosed with heart failure in this country each year. And over 100,000 of these patients will become unresponsive to traditional medical management. So, and due to the lessening number of donor hearts available for heart transplants, the LVAD is now being used as what we call a destination therapy, meaning that people are not necessarily on the list for a heart transplant, but this is their treatment for their heart failure. So this presentation will give an overview of the device and the nursing interventions that will be required to provide excellent treatment to improve patient outcomes. So I thought of 3 areas to focus on that are a little bit different for this patient group. The nursing assessment process is different because these patients usually do not have palpable pulse, and you also cannot use the pulse ox on the end of the finger that we normally are used to using. There is a huge infection risk with these patients as well. The device is implanted into the chest, and there is a line that comes out of the abdomen called the drive line that has very specific dressing requirements. So if they get an infection, it can be really critical to them. And then also this group of patients also faces a lot of self-concept issues, not only the patient itself, but also the family. They are required to be attached to some sort of power source at all times. So they do have rechargeable batteries, so if they go out for an activity, they always have to make sure that they have access to a telephone and an extra set of batteries. So this group of patients will most likely be treated by the heart failure unit, but since we are sister units, I feel we all should be familiar with this. Oh. I was just touching. So this is a slide that I found, and it's from Barnes Jewish Hospital, which is in St. Louis, Missouri. And it just shows that how much the use of the LVAD has increased. Back in 2011, they had 64 cases, and then in 2012, they had 101. So that number will surely rise as time goes by. So I had to submit a rationale for this project, and my rationale was that our hospital and specifically our units will be treating this group of patients in the next couple years, so that, as nurses and caregivers, we should begin to become familiar with what's needed. And also that the LVAD was shown to prolong survival time by 52% over optimal medical management treatments. So it really is effective for our patients that have end-stage heart failure. So I had to come up with a PICO question for this as well, and it's in patients receiving LVAD implantation, what is the effect of customized nursing interventions as compared to traditional nursing interventions on patient outcomes in the post-surgical period while in the progressive cardiac care unit? So I thought I'd insert a picture here of the LVAD. And so this is the portion that is inside the patient, and blood comes out of the left ventricle and circles through this device here into the aorta. So it's really replacing, the inner workings of the heart, and then the blood will be distributed throughout the body. So this line here is what comes out of the body. This is the external controller, and this patient is wearing the battery pack across his shoulders. So that can either be plugged into like a charger at home, or he can actually, move around with that there. So the first area of change for us as caregivers is the assessment. We're used to getting a manual blood pressure with a blood pressure cuff and a stethoscope. However, the patient doesn't have a pulse. So instead, you use a Doppler with the blood pressure cuff. And when you hear the first sound that you hear with the Doppler, that actually corresponds to the mean arterial pressure. So we're not getting a traditional blood pressure reading. Normal is between 60 and 90 milligrams of mercury, and then anything over 90 is considered hypertensive. And then to assess their oxygen level, we wouldn't be able to use a pulse ox because it wouldn't transmit through. So really, we're just using our visual assessment with that. We're checking the color of their skin, mental status, and lip color. And also, patients with an LVAD may not have heart sounds. So, however, there's, I guess, a humming noise that goes along with the machine. So, I guess we're assuming it's working. I also wanted to say, too, there's the LVAD, which is the left ventricular assist device, but there can also be a BiVAD, which would be bilateral, and so there's different types. So, if your patient goes into cardiac arrest, typically we would do compressions. But compressions on a patient with an LVAD can be really, dangerous. It can dislodge the device. So you would never do compressions unless it's ordered by the physician. Defibrillation or cardioversion can be done, but you wouldn't want to place the pads directly over the device. So this is just a picture of a patient getting their map taken with the Doppler and the blood pressure cuff. So another big concern for LVAD patients is the risk of infection I mentioned earlier. So we're pretty familiar with cleaning wound sites with chlorhexidine. So that's pretty much, how it's done as well. A big part, though, would be educating the patient and their caregiver. They're usually, from my research, assigned one person that will go through the process and will receive a lot of the education before discharge, kind of their person, their go-to person. So you'd have to make sure that that person was familiar with the process and could do teach-backs and that sort of thing. And then during the daily dressing change, they also would wear a abdominal binder that seems to help reduce the risk of infection as well. And then I just found some pictures here of like what a healthy, normal site might look like, and then this is a site that definitely looks like it's infected. So psychosocial issues are another area of concern for these patients. They've been through a lot at this point already. I mean, they're either waiting for a heart transplant or this is kind of their last, destination. So they've had to deal with, a lot of issues at that point. But then also knowing that you're going to be released from the hospital and you're always going to have your little bag of your batteries with you, and that really, you're being kept alive, by a machine. So not only, are our physical assessments important, but our psychological assessments too, to see if they need any support, or help. And not only for the patient, but for the family too. And then there are like some safety issues. The big one that I saw was water. So you have to keep the equipment away from water. You don't want it to get wet. And this is actually a picture of a man with an LVAD, and he's fishing, which that must be something he really, enjoys doing. But, there's always the risk. What happens, if you're out on a boat with your LVAD. And then I just thought that picture was sweet of that couple. Oh, I found this little story. This lady, she's 37 or 38 years old, and she suffered a massive heart attack. And so she's actually on a transplant list to get a donor heart. But in the meantime, she's wearing the LVAD, and the surgery to implant the LVAD, they had to remove one rib and shave down 2 others. And she can never be more than 30 feet away from a phone, and she'll always have to have a power supply and backup batteries. available to her. And she has young children too. I didn't include a picture of that, but so that's really something to, you know, be going through that. So I just came up with some recommendations that, you know, for our unit to be equipped for these patients. I would think every room would have to have a Doppler available. I think we only have one that I know of on our unit right now. And that we would have to become, you know, efficient in taking blood pressure in a different way. Our computer charting will change, more charting, I'm sure. And then we have to do regularly scheduled equipment checks. I saw Q12 for that, but I think that should probably be more often. And then these patients are always on some sort of anticoagulant as well. So we would have our teaching that goes along with, you know, Coumadin or whatever blood thinner they're on. And the blood thinners cannot be discontinued unless requested by a cardiologist. And the target INR is usually 1.5 to 2.5. This is a checklist that I found from, it actually is from Medscape. And I guess you can become certified in taking care of these patients. And this is just a sample checklist of all the things you have to be proficient in to be able to provide care. So, you know, we deal with a lot of code situations on our floor, and codes with an LVAD patient is a little bit different. Again, we talked about not doing the compressions unless ordered by the physician. So you want to know if the alarms are activated. So there's alarms on the machine. You can do cardioversion to convert them. And then, so this is, I'm not going to go through the whole thing because I put some copies down there, but it is different in our traditional code blues that we deal with. I think I talked about these. So with the, so any flashing yellow or red alarms, they should be reported immediately. And I'm assuming there will be some sort of go-to person here in the hospital that's available 24/7 to handle any concerns or questions that we would have. And if any of the, if none of the systems checks are passed, then that person would have to be contacted. We talked about reducing infection, temperature of over 101.5, any redness, pain, or drainage should be reported immediately. And of course, any chest pain or shortness of breath. So I'm assuming that we'll have a resource person available to us with any questions regarding the patient's, you know, condition. And I think that would give us more confidence in taking care of this type of patients as well. So, and this is some information I found about their survival rates of LVAD patients post-implant follow-up. So it kind of shows that it really has gone up from 2010. The most recent numbers from 2012 to 2013 have a 12-month survival rate of 81%. That's from the Cleveland Clinic. So I know we have a heart failure pathway program already where our CHF patients are contacted weekly to see, or daily, I think for a couple weeks, to see how they're doing on their weights and with their medications. And I think to evaluate our successful treatment of these patients, we would have to have some sort of program in place, you know, continual follow-up to see how they're doing, see if they need any support and any questions. And, you know, we would always ask them these questions about weight gain, shortness of breath, any problems with their equipment or batteries, you know, any unexplained bleeding or abdominal pain. So my expected outcomes of this project is that it increases our educational opportunities, that we get to broaden our scope of care and learn to take care of, you know, an entirely different group of cardiology patients. I would expect us to become certified, you know, some of us become certified in the care of this group of patients. And we would want our patients to be comfortable before they leave here so that they are getting the same level of care at home and feeling as comfortable as at home as they are here. So in conclusion, I mean, I just think it's really exciting that we're going to be able to take care of these people and bring this technology to the hospital. With an estimated 670,000 new cases of heart failure each year, with 50 to 100,000 of those not being able or unresponsible to medical therapy, I think this is a good option. And so it helps us not only treat, you know, those patients, but I think it provides a good service to our community and surrounding area. Those are all my references. Any questions? No?
So when you was doing your research on the LVAD, what did you find to be the biggest risk for these patients?
Really, I think infection seemed to be a really big one. Not only the driveline infection, which you can visually see, but infection inside, you know, with the mechanical part that is inside the heart. You know, if you get into a situation where the internal portion becomes infected, you know, that's not good at all. And then something that really interested me, and I mentioned this to Regina, was, you know, people that are on the LVAD for destination therapy, that's kind of the last thing for them, their last resort. And they usually have a lot of other, you know, comorbidities as well. And I just think, you know, it's similar to your patient being on a ventilator, you know, deciding to turn that off, except that patient may not be conscious and talking. You know, someone on an LVAD is just, you know, what kind of support do we need to give those families and patients, you know, when it comes time to turn that off? You know, there's a lot more than just the hands-on care, but being prepared to handle them emotionally, you know, so.
I think once those patients get to that level, hospice will be involved.
And truly, the person that you saw who has it and the children on the phone nearby, we have cell phones now.
Right.
And it's, you know, inside, so you're carrying that battery with you. The goal is just they're living their everyday life.
Right.
You know, out there it's not as maybe like it was 10 years ago where you had this big battery and it's cumbersome. Now they live an everyday life.
Well, and if the LVAD helps the heart function more effectively than it was before, it might actually improve their quality of life too. You know, it might reduce hospital visits. They may not have, you know, their CHF exacerbations, you know, quite so often. So.
The heart failure journal just came out with nursing implications for infection for an LVAD patient. So I'll make copies and I'll hang it up because it's great that you brought this up. This was a great insert because it's really the start of what we need to know. To take
Well, it was
care of
definitely, I didn't want to do infection control or falls risk. I mean, that's all very important, you know, but I thought something new for us to hear about would have been interesting.
When Wendy gets a picture of an